Assalamu alaikum and good afternoon, everyone. Today in the grand round, we are, on behalf of Anesthesia Department, we are going to present a lecture. You can see the title here. This will be presented by Dr. Ferhan Ahmed Khan. He joined KKH in June 2023. He had his MBBS from JJ Medical College, India in 2006. He had anesthesia and diploma in anesthesia in 2010 from India, then MD in 2012. He also have European diploma in anesthesia and intensive care in 2018. And he have a fellowship in regional anesthesia from King Saud University, Riyadh. Regarding his work experience, he was working as assistant professor in Yenipoya Medical College, Mangalore, India. And from 16 to 2023, he worked in King Saud University as associate consultant. He is here after joining KKH. Also, he is involved in the teaching of ophthalmology residents when they come on their rotation to anesthesia for a monthly rotation. He's going to talk about local anesthetic systemic toxicity. Local anesthetic toxicity is rare happening, but if it happens, it is devastating. It is very harmful for the patient. So he will be going to talk about the different aspect of local anesthetic toxicity and the management of the toxicity. In anesthetic books, we call it LAST, but this is LAST, not LOST. So, and if at the end of the lecture, if there was any question, then we can have a discussion about that. So thank you for all of you for attending. And Dr. Ferhan, you can comment.
Thank you, Dr. Zahoor, for the introduction. It's my privilege here to present to you an important topic in anesthesia. This topic, as Dr. Zahoor mentioned, it's a rare complication. However, when it happens, it can be quite devastating for the patient to a point where even patient can end up with a respiratory and cardiac arrest. But this is one of the complications which is, when recognized early, it is very treatable. So that's one of the reasons why we have a keen interest with this topic. It's a very technical topic for anesthetists, and it's an important topic, especially if you're practicing regional anesthesia. The incidence of LAST in regional anesthesia overall, it's about 3 to 4 in every 1,000 blocks. The incidence is much lower in ophthalmologic blocks, even though we use similar medication. The reason perhaps is because of the volume of local anesthetic used in ophthalmologic block is much less. However, it has still been seen in some cases of ophthalmology as well. So this is a survey I found on British Journal of Anesthesia done in 2023 regarding the knowledge of recognition of symptoms of LAST as well as management. This is also a survey which is done in a standalone eye unit, and they found that most of the responders were not confident or somewhat confident about recognizing the symptoms of LAST. Because it is a rare occurrence, many of the people may not have encountered it, so they would not know how to recognize that it is a symptom of LAST and to treat. So I divided this lecture into 3 parts. So I would like to go with basics of local anesthetic, so we understand how the local anesthetics work, and that will lead us to understanding the pathogenesis of how the LAST occurs, and then finally I will discuss about the treatment. As stated by Louis Pasteur, in the field of observation, chance only favors the prepared mind. In other words, for us, we need to prepare ourselves to know how to recognize any symptom so that we know that is the cause of it, so we can initiate the treatment at the earliest. A little bit about the history of LAST. about the local anesthetics. It was initially in Vienna by Albert Niemann, who isolated and crystallized pure cocaine. And a company called Merck, they distributed batches of cocaine to different physicians to see how it is useful. Sigmund Freud and Karl Kohler, they were initially came in hand of this cocaine, and they found that it was numbing their tongue. So they thought they could also use it as a local anesthetic, as a topical anesthetic for performing ophthalmologic surgeries. So in 1884, Karl Kohler used it to perform an eye surgery, and eventually around in the same year, Hermann Knapp used cocaine to do a retrobulbar injection for enucleation. Local anesthetics are basically divided into two. There are two major groups. One is the esters, and the next group is the amides. Esters are cocaine, procaine, tetracaine, which is a commonly used topical anesthetic. And in amides, we have lignocaine, bupivacaine, ropivacaine. These are commonly used injectable local anesthetics. So these two are divided mainly based on their metabolism. The amides, they are metabolized in the liver by cytochrome P450 and the enzymes of it. And the esters, they are metabolized by ester hydrolysis. When the esters are metabolized, they bring out a metabolite known as para-aminobenzoic acid. This is an important metabolite because this is known to cause allergic reactions with local anesthetics. Chlorprocaine is also metabolized to 4-amino-2-chlorobenzoic acid and diethyl aminoethanol, which is responsible for its short duration of action. So as you can see, the chemical structures, let me use a pointer. So the chemical structures of local anesthetics are almost similar, except the intermediate chain, the ester chain or the amide chain. So this is the combination we use in our hospital, combination of 0.5% bupivacaine, 2% lidocaine, and hyaluronidase. This is an interesting case I came across as a case report. This was an 82-year-old woman with secondary to post-herpetic uveitic glaucoma. She was given a retrobulbar block with 2 ml of 0.5% levobupivacaine and 2% lidocaine. After 2 or 3 minutes, she became lethargic, and in 5 minutes, she lost consciousness and developed severe hypotension and respiratory arrest. She was eventually intubated successfully and resuscitated with mechanical ventilation, vasoactive medication, IV fluids, and use of intravenous lipid emulsion. So I have a question for the audience. Anybody can answer. What do you think this might be? Yes, that's the right answer. So it was a case of brainstem anesthesia following retrobulbar block. The reason why I bring this up is that the presentation of local anesthetic toxicity as well as brainstem anesthesia can overlap. So both can appear similar. So brainstem anesthesia is found when there is unintentional subarachnoid injection either through the optic nerve or directly through the optic foramen. They have found that if you use a needle more than 40 millimeter long, the chance of brainstem anesthesia is much higher. And depending on also the dose and volume of the local anesthetic spreading there, it can block the cranial nerves as well. Patient usually presents with confusion or restlessness or total spinal anesthesia, quadriparesis, arterial hypotension, and bradycardia, and eventually respiratory arrest. The treatment for this is symptomatic. You have to give oxygen, IV fluids, vasoactive medication, and if needed, tracheal intubation and ventilation until the complete effect of the local anesthetic wears off. A little bit of background of how the local anesthetics act. They block the sodium channel, potassium as well as the calcium channels. They physically cause a block in the sodium channel. So this leads to prevention of a formation of an action potential. So when there is no action potential, there is no carryover of pain or any kind of electrical activity. That's how it blocks pain. A word about hyaluronidase, which is another part of the combination what we use here. It's an enzyme that reversibly liquefies the interstitial barrier between cells. So this helps to spread the local anesthetic through the tissue planes and improves the onset and quality of the block. In our hospital, we use about 15 international units per ml. Recommended is about between 5 to 150. You can use, but ideally it should be less than 15 international units per ml. Now coming to the part 2, this is the pathophysiology of LAST. Cardiac toxicity, one of the devastating complications of LAST. It is usually occurring due to the accidental intravascular injection. As we already know, local anesthetic, they block the voltage-gated sodium channels. They do the same with the cardiac conduction system as well. So this leads to contractile dysfunction, meaning the heart is not able to pump well, it's not able to relax well, so eventually leading to decreased cardiac output as well as decreased blood pressure. Now, bupivacaine and lidocaine have a different form of toxicity. Bupivacaine is a longer-acting drug, is more potent. The way it blocks the sodium channels is fast in, slow out fashion. It means that it blocks the sodium channel very fast, but it comes out of the sodium channel very slowly. So you have a longer duration of toxicity. And usually, the chance of toxicity will be much higher when the heart rate is between 60 to 150 beats per minute. Lidocaine, on the other hand, has a milder form of toxicity because it blocks in a fashion of fast in and fast out principle. It means that it blocks the sodium channel quickly as well as releases from the sodium channel at the same rate. So you don't see a very severe form of toxicity with lidocaine. Now, I'll just mention about the cellular targets which contribute to local anesthetic toxicity. The first target, of course, is the sodium channels. The second target is it affects the metabotropic receptors, which eventually affect the ribosomes. The third, it affects the ATP production at the mitochondrial level. Finally, it blocks the sarcomere, so contraction of the muscle does not occur. So this is the 4 mechanisms by which local anesthetic cause the toxicity. And if you see the spectrum, most of the patient can present with dysrhythmias, meaning it can have tachycardia or severe bradycardia. Some of them can have conduction delay, so they can be having heart blocks. About 20% of them can directly present with a cardiac arrest. So if you want to remember in an easy way what are the cardiovascular symptoms, the early symptoms will be hypertension and tachycardia, which is followed by hypotension and dysrhythmias, which can be either bradycardia or tachycardia or even eventually leading to a cardiac arrest. CNS toxicity, on the other hand, it manifests initially as an altered mental status for the patient. Patient can complain of paresthesia or perioral numbness, tinnitus, or they can be agitated. And eventually, if not treated, it can lead to seizures or possibly coma. So this is another slide to easily remember the different symptoms. Patient presents initially with dysarthria, tinnitus, perioral numbness, confusion, agitation, and dizziness. But if it goes untreated, patient can develop seizure and coma. Now coming to the management, this is an article from the American Society of Regional Anesthesia and Pain Medicine. This is a practice advisory. They come out every 10 years after studying multiple cases of toxicities, and they give the recommendations. So before we go there, we need to know one of the most important medication, what we use in treatment of LAST, that is the intralipid. This lipid emulsion, about its intralipid of 20%, this was introduced in 98 and it has been in clinical practice since. This is a very attractive and important medication for management of LAST because without this, reviving a patient becomes very difficult and the chance of revival is much harder. So this is a very important medication to have whenever we use any kind of local anesthesia block. So let's look at how it acts. Initially, they said the potential mechanism acts as a lipophilic sink. It's going to absorb the local anesthetics, preventing it from acting on the sodium channels. and it takes away towards the liver where it is metabolized. But now they have found that there is much more to it than just as a lipophilic sink. There is active shuttling of the local anesthetic away from the brain and heart, where the complications are occurring from local anesthetics. And also they have cardiotonic effect. It means that it helps the cardia to start pumping well, to relax well, and eventually recover the patient. So this is the shuttling effect, where we find that the local anesthetic from the heart and the brain is taken away towards the liver as well as the skeletal muscle. So away from the areas where it causes the toxicity. So it acts like a dynamic scavenger. The cardiotonic effects, if you see in this graph, when patient has a decrease in cardiac output due to bupivacaine toxicity, without using intralipid, the cardiac output does not increase much. But when you add intralipid to management, there is a sudden increase in the cardiac output, thus reviving the patient. So let's see how it helps. It helps by increasing the cardiac contractility. It helps also in relaxation of the heart so that there is good filling of the left ventricle. It adds volume to the intravascular space, so thus improving the preload. And finally, it acts on the peripheral vasculature by causing vasoconstriction by interfering with the nitric oxide signaling. As we know, nitric oxide is a good vasodilator. It prevents the vasodilation, so hence it improves the preload and afterload. So thus, together with all these mechanisms, it improves the cardiac output and blood pressure. This slide shows an experiment done on animals where they injected with bupivacaine. If you can see on the top, slide A, bupivacaine was injected and their CPR was given. But the recovery of the arterial blood pressure was very much delayed and almost the animal did not recover. To test, they gave bupivacaine and they added intralipid bolus. And you can see that the recovery was much better. They were able to get the pulse back at a much earlier rate. So how does the intralipid bind to the bupivacaine molecules? They found that there are two types of molecules in the body. One is uncharged molecule and a positively charged molecule. The uncharged molecule is trapped inside the hydrophobic core of the lipid, and the charged molecules are attached to the negatively charged intralipid molecule on the surface. So this is how it attaches to the bupivacaine molecules, taking them away from the site of action and preventing the toxicity. So in this study, they also found there is changing in the presentation of LAST. The 40% of the patients who came with this toxicity did not have a classical textbook description of LAST, which was initially CNS symptoms followed by severe symptoms. They found that rather than a patient presented with mixed CNS toxicity and cardiovascular toxicity at the same time. So this was deemed as an atypical presentation, or they found a small batch of patients presenting directly with cardiovascular signs alone and no CNS toxicity at all. And they also found that many of the patients had a delayed presentation. It was not an immediate presentation. It was presented after 5 minutes up to 60 minutes. So in this pie chart, they have differentiated patients with CNS toxicity alone, 43%, a mix of CVS and CNS, 33%, and cardiovascular toxicity alone was about 24%. So also, like I said, the presentation was delayed, some patients up to 60 minutes after the injection. So with this, they recommended from 2010 that patients should be observed for at least 30 minutes after the block to make sure that we don't have any kind of a complication. Regarding treatment, they recommend early respiratory treatment. The reason is that patients who have hypoxia, hypercapnia, and acidosis have a poorer outcome due to toxicity. So early intubation, early ventilation is essential. Secondly, we need to have an effective CPR. Without effective CPR, the intralipid emulsion what we give will not be effective because the perfusion of the heart is important for the intralipid to reach so that the sodium channels are free of bupivacaine. Third, when we use epinephrine, like we use epinephrine in ACLS protocol or BLS protocol, we use 1 milligram directly for every case. But here, the recommendation is to use a lower dose of epinephrine, about 1 microgram per kg or less. The reason is that they have found higher dose of epinephrine causes impaired pulmonary gas exchange as well as increased afterload. When there is an arrest, we have to follow the ACLS protocol, except there are a few changes. Epinephrine, like I mentioned, should be in lower dose. Vasopressin is not recommended. It has been found to have an adverse outcome with it. And we have to have use the intralipid at an early stage, and we have to have good chest compressions to make it more effective. Also, when we have arrhythmias, we use lidocaine as an antiarrhythmic, but in this case, we should avoid it. Amiodarone will be the first-line antiarrhythmic for these patients. And likewise, calcium channel blockers and beta blockers, both should be avoided when there is a last. And in case of patient cannot be revived, cardiopulmonary bypass should be started at an early stage. Okay, so this is the algorithm we have to follow when we have a patient with LAS. When we recognize the symptoms of cardiovascular and CNS, such as tinnitus or sudden altered mental status, or patient has a bradycardia or a cardiovascular shock, first thing we have to do, stop injection and call for help. The next step, and both of these steps should be done simultaneously, start lipid emulsion therapy, as well as support the airway. Do 100% ventilation with 100% oxygen using a mask, and intubate the patient if needed. So dose of intralipid, for a patient more than 70 kilo, it's very simple. Use a bolus of 100 ml. It comes as a 250 ml bottle. From that, you can straight away give 100 ml for the patient. If the patient is small or if it's a pediatric one, you can give about 1.5 ml per kg. After that, to maintain stability of the patient, you can give a continuous infusion of 0.25 ml per kg per minute. And then you have to reassess the patient. Simultaneously, as we are doing an airway support, we also should focus on the cardiovascular support, treat the patient's hypertension by giving IV fluids, and treat the bradycardia as needed using epinephrine. And also remember not to give vasopressin, beta blockers, calcium channel blockers. And if the patient has seizure, you can use benzodiazepines. But be careful about using propofol, as propofol also can cause severe hypotension. Like I mentioned before at the beginning, that one of the metabolites of ester hydrolysis is para-aminobenzoic acid. So this is known to cause allergic reactions due to local anesthetics. So we should be cautious about using that. Also, a preservative called as methylparaben, which is present in the bupivacaine, what we use, also is known to cause allergic reactions. So what do we do when the patient has an allergic reaction? We need to first support the airway with 100% oxygen and use beta-2 agonists for improving the ventilation to cause a bronchodilation. Use steroids, dexamethasone or hydrocortisone in the beginning. Volume expansion, elevation of leg, as well as giving IV fluids for the patient. Epinephrine can be used in incremental doses, about 50 mics to 500 mics as needed. And repeat a dose of the epinephrine if needed. And then we can continue using antihistaminics as well as steroids for management. A quick note about local anesthetic use in aging population. As we have a lot of geriatric patients in our hospital, we should be cautious about the doses what we use in them, because neural sensitivity is higher in aging population. They have increased body fat and decreased total body water, so the volume of distribution is reduced. They have hyperalbuminemia, that means increased free form of bupivacaine is available. Increased free form means that it is more likely to cause a toxicity. Their liver and kidney function may not be like how it is with an young adult, so metabolism of the medication is also delayed. So with all these reasons, we need to be cautious about reducing the dose of local anesthetic from 10 to 20% in aging population. To summarize, patient characteristics are important. So first is a very young patient or a very old patient, we need to be cautious about the dose, reduced by around 20%. Patient with low muscle mass, especially neonates, infants, and debilitated elderly, we should be very cautious about the doses. Patient with comorbidities such as cardiac disease, especially patients with conduction defects, patients with heart failure, patients with liver diseases having hypoalbuminemia, we should be careful about the dosing and reduce the dose by around 10 to 20%. Also remember that depending on the type of local anesthetic you use, like bupivacaine is more prone to cause cardiac toxicity as compared to ropivacaine or levobupivacaine or lidocaine. And also they have found that about 20% of last cases, they occur in outside of the hospital setting. By this I mean that it could be a daycare center, it could be a standalone eye center where you don't have adequate restorative measures, people to help the patient. So 20% of the patients occur in these places, so people should be aware of how to recognize and manage these cases. So with this, I would like to conclude my talk. I appreciate you guys for listening, and hopefully it was a useful talk, and hopefully it will be useful in the future for the clinic. Thank you.